So undescended testes is looking down at different themes. So as far as alignment, so some to be intra-abdominal, some are in the groin, some are high in the scrotal area. The ectopics are similar in similarity, just not in the true alignment. So let's try to figure out. So what percent of patients that have an undescended testes have a patent processus vaginalis? So would have hernia defect. So sometimes it's a cross between an elephant and a rhinoceros. Hell if I know, I just don't know. But about 80% of the time, an undescended testes, especially if it's in the groin, will have an associated hernia defect. And that's actually part of the repair. So if you're going to repair this undescended testes, it truly needs to be brought down. You're going to repair the hernia sac too. So as urologist, we won't be surprised that we'll see that, and that's part of the actual correction. By taking that sac away from the cord structures, gains length to bring it down to the scrotum without tension. So 80% is the answer. Of undescended testes, 3% of the time at neuroborn period, they'll be undescended. It's like it's not there, it's not in the scrotum. Don't worry. There's a good potential within the first 3 months of time it'll show up. So we just give it time and just come back and reevaluate at that point. 80% of the time you'll feel the testes, but up to 20% of the time you will not be able to feel the testes. And 50% of those that you don't feel are truly not there. And the most common cause for it not being there is a torsion intrauterine. So during the time, even before the boy has been delivered and out and about, the testes has rotated on its blood supply and knocked off its blood supply. That's a torsion event. And you may be able to feel something at one point, but as they go into 3 months, 6 months, they come back, and what you felt now is smaller and smaller. So I'm like, oh man, it's getting smaller before our eyes. It just means it went through that event. It was not evident at the time of birth that anything had occurred. They could just feel something, and now it's smaller. And that smaller is really because it is torn. So you have to go into the premise that that's what the scenario is. As far as how to manage that. If you have a non-visible testes, though, 50% of the time it's going to be still present, it's just intra-abdominal. So you manage that differently. You wouldn't go through a groin incision, but go laparoscopic, a little nick in the belly button, take the scope in, see where the testes is, and see if you can bring it down to one stage, or most often you require 2 stages, where we clip the vessels, because sometimes the vessels are too short, but the dual blood supply of the testes has one, the basal arteries, the arteries alongside the vas deferens, and the second blood supply is the main trunk. But you can take the main trunk, come back in 6 months, and that small vessel along the vas deferens is now augmented. It's a big vessel. It says, I got your back, I'm a tougher vessel now. And it's more easy to bring that down successfully than trying to do that in the first stage altogether. So don't feel like it's there, I'm going to try to bring it down. Don't be a hero. Come back and later bring it down safer with a greater potential of accomplishing that you need. So if you're trying to see, can I feel this testes or not feel the testes, and kind of feeling around, I'm not sure. One of the better ways to do is get a little lubricant on your fingers and go into the upper groin and sweep the upper groin down to the scrotal area. So as you're sweeping this area, a little boop, you'll feel this little pop. A little pop is the testes going between your fingers. So you can't feel it easy, and you want to be able to show it to the parent and think, I think I can feel it. And you just swipe along there. You have to put a little pressure, though. It can't just be kind of just softly. You kind of got to put a little bit of pressure, and then that testes that maybe not as easily felt independent will then show itself, especially in the inguinal canal. That's why popping on between your fingers. That's one way of demonstrating something that may not be able to be seen on routine examination. So we got a true and false question coming up. Oh boy, oh boy. All right, here we go. So monoorgan. So if the child just has one testes, is this going to really diminish their potential for paternity? No is correct. It does not diminish. So the testes has a potential, if the other testes is absent, to have compensatory hypertrophy. So it's got its fertility on its mind. So I'm going to be a bigger testes, bigger, bolder testes. So it'll muster it up, and it's just be that. It'll be a bigger testes. So a lot of times if you're in there and one of these testes are truly small, I suggest maybe you want to have a testicular prosthesis, and so you can put that in at the same time that you would remove the testes if they have them. So if we're going in, it's got a 50% chance it may not be. I've talked to the parents also about, if we do not find a testes, would you like to have us put in a testicular prosthesis? Used to be pretty complex that they would always reject, and then torture the nurses trying to get all these approvals of, can we get the insurance to improve this prosthesis? And then it became okay because it equated it with a breast prosthesis, right? Women had breast cancer would prefer to have a breast prosthesis if all possible. They had to wrestle with that a little bit until they realized, hey, they didn't bring it upon themselves. They just would like to be back to normal as much as possible. So then it became part of standard of care, right? Breast removed for cancer, absolutely line them up for a breast prosthesis if they so desire. So I equate it with that. So then when they rejected it, because they often did, why testicular prosthesis? I said, well, is this kind of like discriminatory against the little guys? I mean, they didn't want to not have a testes. Why can't you give them a prosthesis? So we usually won that battle. But nowadays, insurance are tightening the screws, and so we still have to sometimes battle where we didn't have to battle before. So thank you, Obama. So for acute scrotums, you'd probably be familiar with this, but this is an aside because I've seen it as children. Testicular torsion is a real urgency thing you want to correct and see in adolescents, but it also happens in infants, like we just talked about. So it's one of the reasons why you may have an absent testicles occurred in infancy. Testicular appendage maybe is not as well known or understood, and how to evaluate that we see, but this most often occurs in childhood. So the bimodal time periods where testicular torsion occurs around infancy, even before birth, and after puberty. That's when true torsion occurs. Now, does that mean you're excluded from ever having testicular torsion between those two ages? No. You can get a 4-year-old or a 7-year-old comes in, and it's odd in their presentation, but they're kind of swollen and red, and you say, it's probably nothing. No, it probably can be something. So they still have to be evaluated as if they have testicular torsion to make sure you have good blood flow. But more often, doesn't mean it's exclusive, but more often it'll be a torsion of the appendage. So we want to show you a little bit. So testicular torsion, so you got a 720 going on there, and it's starting to get a little bluish, like a robin egg. And the one down below, that's the end, so you completely infarcted the testes. So over a period of time, blood flow in has led to so much congestion that it's end artery obliterant. So it's obliterated the potential. So even though you untwist it, it's still without perfusion, it's a goner, so you take that one out. But we want to get, so the key is you got to get there and get there soon. Fix it before too late. And this is showing the appendage. So this is what people a lot of times don't see and understand. So the appendage is a little structure, just like we have an appendix in the abdominal cavity as far as off of the colon, right? The appendix, appendicitis. There's an appendage off of the testes as well as the epididymis, the structure right behind the testes. So you can see the schematic on the far left. Here is the blue dot sign, which you rarely ever see, but you could maybe perhaps see what you're seeing on the far right-hand lower. So this hemorrhagic congested testicular appendage in a Caucasian from Norway who has very thin skin. Maybe you'll see this blue dot sign. But you see the appendage in the upper right, that's this little fingerlet off, and see how narrow that is, right? So you can twist that pretty easily. It has a single solitary blood supply. But anytime you have low blood flow to any solid organ, heart, right? Yeah, Mike, right? So heart, so you have pain. So you have chest pain when you have a heart attack because you have a partial occlusion to a coronary vessel. If you have partial occlusion to a testicular tiny little appendage, it's pain because it's a solid organ. So that's why they have the pain there, is because it's impeding infarction and loss. Usually when that occurs, and that it really is infarcted, and so it's usually the one distinguishing thing for testicular appendage torsion versus testicular torsion. Usually if they have testicular torsion, it's more visceral. They have upset stomach, feel nauseated, sometimes vomiting. It's not just in the scrotum where it hurts, but it hurts abdominally or in the groin. Where appendage is usually, they can be like a happy kid, but if they move or you touch them, like, they're very pensive. So any manipulation or movement or touch, they're like, whoa. Whereas if a person just has torsion, they're just hard to get comfortable even if they're sitting. But if somebody that has appendage torsion, they're more apt to only uncomfortable when touching or moving. But that doesn't seal the deal. You still probably need to get that ultrasound. I think it's important to just see what you're dealing with there as far as the picture. So concealed penis, the hidden weapon, right? So what is it and why is it? This is like real common. Like when we have a clinic, we'll have, this is the circumcision doesn't look right. If you have circumcised, no, it doesn't look right. Why? Why didn't it work right? And the issue mainly is the concealment. So I always do this with the parents. So if this is the penis, okay, it's a thumb, right? But this penis, and the pubic skin typically aligns horizontally at the base of the penis. And this alignment allows for full exposure of the penis. But there's variations of the theme, like in everything. And the variation on the theme is instead of horizontal alignment, it may be oblique. And if it's oblique, then if there's going from a standing position to a sitting position, then it can dunk down. So it would be a tortoise head and a shell that's more evident. The erection is still going to come out, but when it's flaccid, which is 98% of the time, then it's going to be concealed. And when they're sitting up, then it really dunks down completely. So it's not because, they're always concerned, well, poor guy's just a little short change. They're not. It's normal shaft length and diameter. It's just they're not exposed. So at the time of newborn circumcision, they may not recognize that, and they're trying to do the best they can to get the penis to be exposed, and they're taking off too much of this and taking off too little of that, and the result is it doesn't look right. And so if I see, it's rare that we get called to come evaluate a child for a circumcision, but it's somebody knows me or says, would you mind taking care of my child? Or our last boy had this problem, could you take care of it? We have another boy, would you mind taking it? So we get an invitation to go evaluate. And sometimes I'll just say, probably shouldn't do a circumcision now. We'll get it done later, but better to do it later and take care of both problems instead of taking care of one problem now and have to do another thing later. Because if you're uncircumcised, you got extra foreskin, you look normal. You have a unconcealed penis and you had a circumcision, you don't look normal. When I changed my son and he changed it, there's too many other moms that are looking going, what happened to him? So it's better just to let it ride. We'll say we'll deal with this later, and instead of putting them through the torment. So we just have to talk people down and realize that, as far as when to do this. So I used to get involved, feel bad, so, we'll get it done as soon as soon. And I used to try to repair them at 4 months and 8 months and stuff like that. The greatest degree of adiposity in the pubic area, the baby fat, is around 9 months of age. So if they look a little concealed at 8 months, or at 4 months, guess what they're going to be at 9 months? Like, whew, where did it go? It's gone. Because you got the two first. So you're here, and then you got this. So this puppy is really dumb. It's really way down. So, but around 18 months, a year and a half, things have kind of stood out a little better. So you can repair at 4 months and go, yeah, we got it straight. But then you're fighting this battle. And so it looked good, but then you have tension against what you repaired, and that may release. And I learned that. And so that's why I wait typically until they're about a year and a half before doing the repair for greater success rate and outcome of the procedure that you would suggest that they would undergo. They may show face down the road too. So they have a potential that they may show better exposure later. So not to do anything unnecessarily. So here's this poor guy hiding in his shell over there. So that's a little bit buried, right? So this is different variations of. So webbing is also another thing where the scrotum can be tented up against up against the base of the penis, where it's really the penis here and scrotum here is like, whoa, this really attaches all the way up to the front of the penis and can be tenting the penis down, or again pulling things ventrally. It's not cord D, it's this penoscrotal webbing, which can be corrected. That's not something that the penis very goes in the middle line, goes dink, and that goes away. That is something that would require correction if it's pretty profound. It can be done at the same time. Well, hypospadias is another variation of another congenital anomaly or pediatric urologic thing we see. It used to be a little less prevalent. It's becoming a little bit more prevalent. I don't know if it's estrogen exposure through the years, but from 1 in 500 to 1 in 250 over a duration of about 20 plus years in the 1793. There's familiar tendencies a little bit, so if dad has it, there's not a high chance, but about less than 10% chance that a child may. But if a sibling has it, then it kicks up to about 15%. Most of the defects are distal, down the shaft, toward the tip, not more proximal. These openings can be even below the scrotum in perineal hypospadias. So little variations on the theme. Things don't look it's usually a tripod thing. So it's extra skin on the back side, deficient skin on the front side, a bend of the penis ventrally, and the opening's not at the tip, but rather somewhere on the underneath side. Hypo in the Greek, so underneath, spadic, like a shovel, a spade. So it's flat instead of rounded. And so the correction is creating a proper groove and then bringing everything back in layers. And it's about a 5-layer repair. Urethra in 2 layers, then vascularized pedicle flap over that from usually the dartus, the skin of the backside, you flip to the front side, and then bring the gland in 2 layers. So you bring all these things, 5 layers. That looks great when you finish, but some of these things may heal great, but sometimes they may be under a little bit of distress. They may need to do revisions at times. Usually for the more proximal repairs, it require much more reconstructive efforts. This is a Netter diagram again showing all the cascade of varieties on the theme from above to below. This is an angry-looking guy. So this is just core D only. So he may have a proper position of the opening, but he has a little variation on the theme. And so he's like, so this is just a correction of the core D. Now core D is little fibrous attachments underneath that just cause a bend forward. So you just correct that, and it doesn't require any correction of the actual opening. So question time again. You're like, everybody batted 100% of that first one. You have a question?
True micropenis.
True what?
Micropenis.
Yeah, great question. So the big question is, because when parents come in and they think, this sounds really small. So micropenis is a dimensional, true anatomical size. and it's less than 2 centimeters in stretch penile length. Some will equate the glands of being a certain diameter and width, but most of it is on stretch penile length that's across the board underneath the textbooks. So if you want to say, is this really a micropenis, it would be the length of the stretch. So it's not like you just pull out that ruler and try to get a sense, but you kind of get a feel for what is 2 centimeters on your finger. So as you pull, you can put your other finger aside, oh, it's more than 2 centimeters. So that's the main aspect of dimensions and size. Now, why is that important? Micropenis can be helped by administration of testosterone, and probably the earlier the administration, the better response you would achieve. So you can give children testosterone injections. That can be done every 3 weeks over a course of how many injections you feel appropriate to administer early on in life, or even later, but earlier probably better to achieve the best return on injection application. So not topical, but IM injection. It will allow them to restore closer to the mean of normality. So if you feel that this may be a small true dimensional length, if measured and confirmed, so 2 centimeters is greater than 95% off the deviation of the mean. So how do they come up with 2 centimeters? So of all lengths and sizes and variations, so if you're greater than 95% off of that confidence curve of true measured length, they are in that less than 2 centimeters in stretch penile length.
When's it typically diagnosed?
Usually the parents are concerned, or the pediatrician does. And so often we'll see that individual early, but sometimes they show up and they're 4 years of age and they're just wondering why things are lacking. It doesn't mean, oh, sorry, you missed your window, we can't administer right now. Also, never to get involved in injection early, as in the first 4 or I think 6 months of life. Why? Because at 6 weeks of age, they have a testosterone surge. So it's a natural event that occurs at 6 weeks. And you have this testosterone that goes up and then goes back down and stays down until puberty kicks in. So during that time, if you mess with that cycle and administer an exogenous testosterone, it'll blunt the normal response. So that's why, just say no early on. It's like, oh, this is way too small, I better give them something. No, wait. But reevaluate at 6 months of age as far as deciding when to administer. Great question. Anyone else? Okay, got it. So what's the question we got on the panel here? So what percentage of patients with hypospadias and a unilateral palpable undescended testes have intersex conditions? So this is the example for patients hypospadias, just like we saw at garden variety, but they also have an undescended testes, but you can feel it. So what percent of that patient would actually even have true intersex abnormality? And what if the gonad is non-palpable? What if you don't even feel the gonad? What percent chance is that? So there's about a 15% chance if you have undescended testes and hypospadias, you have to look a little bit further to confirm, is there any potential there may be an intersex disorder? So you want to know more about this testes or gonad that you can feel, but it may be an association. And if it's non-palpable, you're up to 50% of the time. So the most common abnormality that's an intersex disorder is mixed gonadal dysgenesis. So to go over a whole topic of intersex would put you to sleep. That's just really detailed and a lot of stuff, and a very small population be involved in their care. But this is probably the most common intersex condition, so to be aware of it. Undescended testes and hypospadias, and you can't feel that testes, ding, 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 you have to think, could this be MGD, mixed gonadal dysgenesis? Why is that important? Because what that means, if the condition is not like, well, then they have like uteruses and fallopian tubes, all that stuff. No, this is just, you have, instead of a testes, a streak gonad, dysgenic, so it never developed. In fact, there's some dysgenic tissue there that's abnormal, and it's typically intra-abdominal, you can't feel it. And it's important because dysgenic tissue in pure gonadal dysgenesis, mixed gonadal dysgenesis, dysgenic tissue can have the propensity to develop, like we'll talk about later in tumors, a gonadoblastoma. So this could lead to development of a tumor that if you weren't aware and dealt with earlier could be in a stage that's not preferable instead of identification and eradication of that earlier in life. So if they have something like that, you want to see it as an MGD, that's a chromosomal analysis. We'll detect that and confirm that for you. Okay, hypospadias, our goal is to make it look ideally as good as, better than the typical appearance of a circuit. That's our goal. And one stage repairs, and then there's 2 stage repairs. So if you have these really severely bent penises, 90 degrees, greater than that. Rare can you do that all in one step. So we do what's called stage repair. So job number 1 is get the penis straight with grafts and the like. And job number 2 is zip up the urethra from where we've got a 2, we use the penis coil junction, getting it all the way to the tip of the penis. Varicoceles. So varicoceles are probably pretty common. You're pretty aware of that, being urology and nursing. But the commonality may not be as familiar. So 7 to 12% of adolescents going on forward will have varicoceles. So it's a very common condition, right? So if you go to the Bears game, you'll look at all these patients, individuals, patients, everybody's a patient, right? So you look at all the fans, they're going to leave early because it's already out of control. There's a lot of people that have varicocele, right? 10%. So varicoceles are common, and it's the most common cause of male factor infertility. So a couple's trying to conceive, there's female cause, male cause. The most common male cause of male factor infertility is astheno-oligospermia. It's really good for Scrabble. Astheno-oligospermia. Put a couple Z's in there, you're going to win. But the most common cause of astheno-oligospermia is a varicocele. So it's a heat temperature thing, so it heats up. So dilated veins lead to increased temperature, which increase about 2 centigrade, the local temperature environment, which lead to spermatogenesis, and even some degree testosterone production reduction. So even varicocele may have an effect on testosterone as well. So that's the ones we consider repair. So again, it's a venous leak. So what is a varicocele? So varicoceles in the legs, you can see on big dilated veins. It's the same thing that can happen in the varicocele and to the testes. So it's a leaky valve. So valves are what allows the blood that is in veins to get back to the heart. If you don't have any valves, it's just going to pull in your toes, right? But if everybody stood up, you didn't have any valves, you'd fill up and you'd have your whole sock full of veins, of venous return. So the valves, which is as these veins typically go through muscle contracts, it's sending it north, and the valves are shutting down the ability to go further, following gravity downwards. So if valves are incompetent, instead of closing like this, they're like this, then that venous blood engorges in the varicocele in the male, then it's engorging around the testes. So the best varicocele evaluation is standing up, because if you're not standing up, you're laying down. Yeah, I think I feel something. And it's quote unquote a bag of worm seal. You feel something like, oh yeah, there's a bunch of tissue in there, and this ends up being veins. By standing up and holding your breath and bearing down really elicits the response. It's the grade 3s that are most problematic for risk. So if you have grade 1 or grade 2, grade 1 is you really don't see it except for ultrasound. Grade 2, you see it, but you have to have them stand and bear down to really witness it. That's really grade 2. Grade 3, you drop them, there it is. Grade 3s are the greatest risk for infertility. Grade 1s and 2s may not lead to anything. So it's not like we have to repair grade 1 or grade 2. We see a lot of patients come in for a vasectomy, they have a varicocele, but they're usually not grade 3s, they're usually grade 1 or 2s. So not every varicocele is going to lead to infertility, but of those that are grade 3s, they have the greatest likelihood to lead to that. Now for collecting cysts and adenomas. So the most common obstructing condition in the in the urinary tract, once urine is produced, is the ureteropelvic junction. So the junction between the kidney and the ureter, the UPJ. It's in about 40% of all dilated systems, this is where the dilatation is going to arise from. It's going to be that junction. So during development, around 12 weeks of gestational age, the kidney actually develops in the pelvis, the true pelvis. So the ureteric bud branches off of this bladder that's developing, and it hits the metanephric blastema. So these tissues are formulating in the pelvis and then ascending. And as the ureter and then this blastema comes out of the pelvis up toward the flank position to reside in the anatomic location typical. This cylinder, which is obliterated, is the ureter, then cannulates. And it does so from the middle outward. So this ureter initially is a solid tube, and then it becomes a cylindrical conduit for urine, because urine starts to be produced around 12, 14, 15 weeks. So this has to cannulate to allow urine to go down. So the incomplete cannulization of this tube is your obstructions. If it didn't completely cannulate up on top, UPJ, down below, UVJ, middle, mid-ureteral, which is pretty rare. But this is the incomplete cannulation of that area genetically. So if in utero, if we're looking and they see that they got a diameter of the renal pelvis, the collecting system just outside the kidney is greater than 20, those often are something that may require attention, even to come to repair at some point in time. And about 50% of these are detected antenatally, especially with antenatal ultrasound. So what do we do with these? And we just mainly do serial ultrasounds in the office. I'm blessed with a really good staff that's willing to put up with a lot of my idiosyncrasies, and the things I like to do is really do the ultrasounds in the office. It's really great for the parents. They just come and do a one-stop shop. All right, let's take a look, and we can look today. And Renee goes, oh man, not another one. But it's really sweet for the parents if they can do that, or maybe more so they rope me into reality a little bit more. Say, can we just do it when you come back next? Got it. Because these are things we're going to follow in the long run. So they can just come back and we just do on-spot ultrasound in the office, take a look, and show them real time what it looks like instead of having mom drag all the kiddos to the radiology, get the ultrasound, then come to the urology office to look at the ultrasound with them. But you have to pull it up, and they have a certain impression, and you have a certain impression. So it's nice if you can have the capability to do them in the office. But anyway, so if you have UPJ, you have to do a renal scan. You don't have to do a renal scan because that's when you really think, is this pretty bad, grade 3 to 4, that's not changing or reducing in size. Most of these will regress and not require repair. Most of the time, they can look big, bad, and ugly initially, but they may not. So you just watch with ultrasounds. But if they stay persistent, that's when you want to define to what degree is there obstruction and what's the differential function. How does that correlate compared to the other side? So you do a renal scan. The renal scan tells you quantification of differential size, or differential function, as well as how well does it eliminate. And so that's cleans the deal as far as do you need repair or not. VCG, if you see a dilated urethra, that's when you want to know, is this reflux that's causing this, or is it true obstruction? So that's when sometimes the VCG, but only if they have a dilated. If they don't have a dilated, no need for that system assessment. So repair of that's typically now done robotically, which is nice. Is that the 5-minute? Woo! Okay, so robotically is one way to repair. This is typically how we repair these now. Now, if the child's too young, then we'll do that, have to do an incisional. Sometimes that's necessary underneath the 12th rib. So UPJ repairs, you disconnect the abnormal area and hook the good stuff to good stuff. That's a repair. You put a stent over that. A primary obstructive megaurethra looks like this. So it's a big sausage, which is very typical, like we call it a peg leg. Got this little tiny little area that doesn't have proper conduit there, and that's why things back up. You can have non-reflux and non-obstructive megaurethers, but more often they're obstructed, and they may require repair. So in treatment of a megaureter, again, we monitor these. If they do need to be treated, we just have to make that ureter, get rid of that little segment that's abnormal, it's not allowing urine to pass through. And why does the system dilate? Well, that system dilates because of pressure, but the system's very elastic, so it takes that pressure and accommodates it. So it takes pressure off the manufacturing component of the kidney by stretching. That's a reflex that's protective to have the stretch. But you disconnect that area and then plug the ureter back into the bladder. So you taper it, you narrow it to a proper size. Sometimes ectopic ureters, so this is now a ureter that has missed the mark. So instead of being in the bladder, now it's ectopic. 80% are associated with double systems. So double system is not two kidneys, it's one kidney with two parts, an upper part and a lower part. This is more common in females that have big systems. And male that drain externally, usually into the area between the vagina and the urethra. They'll see a little dot. And if you can press on the side where the dilated urethra is, you'll see a little expression, a little dot, sometimes of that right at that junction. Most common anatomic location. In males, ectopic ureter usually goes into the prostatic area. That's where in males it occurs. So here we're seeing on the far left, that's a double system. So you got an upper portion, and the upper portion of the kidney goes low. So that's going to be the ectopic location. The lower half of the kidney goes high. It can often be refluxing. So that's why in duplicated system, you may have a refluxing lower pole and an obstructing upper pole. And you can reroute things, just rerouting of the plumbing. Plug this one into here, plug this one into here. Sometimes you do a double barrel implant, but often they're requiring some type of repair at some point in time. So question coming at you. How common are duplicated collecting systems? 0.8% of the population will have this, and an increase in as far as families, about 12% in families. And what percent of duplications are incomplete? So incomplete means not two tubes entering in either abnormally or normally, but actually combining. So a Y communication instead of two separate communications. So incomplete. And of those that are incomplete, so there's more Ys, right, than there are complete duplications. So a lot of times these things Y, and it's duplicated, but it's coming together as one. Like this whole room here, we're coming together as, okay, I know, just get done with your talk, right? Okay, so ectopic ureters. You treat those by individual cases. Ureteroceles are things that go into the bladder, but as they go into the bladder, it's a big distension, and it's like a little collection of fluid because they have an abnormal opening. So it distends inside the bladder, that's the ureter. And so some names, they're ectopic, they're stenotic, enteric, they're supercalifragilisticexpialidocious. There are different types of ways that these things can actually insert in. I mean, you just treat them individually as you need. But a lot of times you can treat these things by just nicking the urethra, allow it to decompress, and then deal with it later as far as reconstructive efforts. So transurethral puncture urethra, the tupu, is something that, so you just nick the opening and allow it to drain to, and it can almost look normal, but a lot of times once you do this, if they're really abnormal, they reflux, you may have to deal with the reflux aspect of that. So pediatric oncology, so neuroblastomas. Who here has even heard of a neuroblastoma? Wow, I guess we good. So this is the most common tumor. Is it in the genital urinary system? Well, if you count the adrenal gland. But these are sympathetic things. There's 95% present in childhood, less than 2 years of age most often. They're neurocrest or the sympathetic chain, most often an adrenal gland. They're the most common malignant tumor in infancy. And so it's the most common solid tumor. So you have to be aware of it. What's the most common solid tumor is a neuroblastoma. They may be metastatic in presentation 70% of the time. It's usually because it's the amplification. So a lot of this stuff is all genetically evaluated now too, so NC-wise. And if child's less than 1 year, they're going to do better. These things may regress and go away. That's an amazing thing about it. So not every one they have will have to do something about it. But they go from malignant to benign. They can do that too, which is really cool. But some may be extremely malignant and can be bad players. RMS, Rhabdomyosarcoma, most common soft tissue sarcoma in infant and children. And 15% of all solid tumors in children, and 20% arrive from the GU tract. Most common prostate, then bladder, then peritesticular vaginal uterus. This is bimodal. It can happen in around 2 years of age. Is one of their peaks. The next one is early adolescence. Is the next peak of bimodal presentation of the rhabdomyosarcomas. The most common, as far as architecture, embryonal, alveolar, and pleomorphic. So embryonal is the most common you see in the genitourinary system, and it's like a bunch of grapes. They're going to have a film like a botryoides is a common expression you're seeing. You see this abnormality usually because of microscopic or gross hematuria in the urinary system. The peritesticular rhabdos are typically present at stage 1 or low grade, and it can be therefore cured, which is great. Organ-sparing therapies are preferentially performed for the bladder if at all possible. Unfortunately, when they present in the vagina or uterus, it's a poor prognosis, usually because of late detection. Wilms tumor, this is probably the most known GU malignancy, and they're the bad boys of the kidney. Now, this is the healthy child. It comes in, they got this belly, looks like it's a little big, but they're happy and playful, so they don't look ill. Neuroblastoma kids look ill, and they got a mass. This doesn't look ill. The most common mass palpable in a child is not a tumor, but actually a multicystic dysplastic kidney, MCDK, which is just a bunch of collection of cysts, which is non-functional kidney, but it's not a tumor. It's not a tumor, so it says Arnold, right? So, but these are tumors, but a congenital mesoblasthic nephroma, which is a variation of this, it presents in infancy as a tumor, and that's not a bad guy. It's actually benign, but you got to get rid of it. You got to take it out. So you just take it out, and then it's done, resolved, and cured. They often associate with other congenital anomalies. If they have aniridia, iris abnormality, or hemihypertrophy, they may have those entities in and of themselves will have a propensity for developing these tumors. And other genital urinary anomalies can be associated with these tumors. So you have hypospadias UDCs or hypospadias and a UDT when you have a Wilms. So if they have these, doesn't mean you better do screening for Wilms tumors, but realize there is some degree of association with that. Mapping genetically is big now with deletions of 11P, 11P15, 1P, 160. Just know that there's some genetic mapping that goes along with this as far as test questions, right? Local recurrence. So the big thing here is go ahead and get that bad boy out of there. And if you can, you did a great thing. But if you spilled or there's not an adequate lymph node dissection that you took out other tissue, there may be recurrence up to 43%, which does not fare well. So there's favorable and there's anaplastic. So like you have somebody named Anna, but her middle name is plastic, you get that middle name coming, you know there's trouble, right? Anna and plastic. So those play a little bit worse as far as mortality. So other rare conditions are, clear cell rhabdoid, not rhabdomyosarcoma, but rhabdoid, the multicystic liger, is a true malignant kidney condition, but it's not a multicystic dysplastic kidney. So if it's cystic, you have to make sure, is it a non-functional cystic, which would be multicystic dysplastic, don't worry about it, or is it functional? There's some function there, then it might be a multilocular cystic, which may be a tumor, which you may need to deal with. Okay, got it. So renal cell can actually occur in children. That's what I remember taking care of a couple of those in children's angiomyolipomas. Testicular teratomas, yolk sac, and epidermal cysts. So you can have testicular tumors, but these are good players actually. If you just take that out, you're done. And the fact is, even with the epidermoid cyst, if you can think that it really is that, you can do a partial orchiectomy. So instead of the whole testes has to go, you can excise just that and be curative in that measure. So if we can feel that that puppy is what we're dealing with, they don't have any elevated markers, beta-HCD, alpha-fetoprotein, or LDH, they may be dealing with like a monolayer teratoma. That with intersex, like we talked about a little bit earlier, the mixed gonadal, you got to deal with those because the gonadoblastomas will variably develop in those children. So that's why you want to get rid of that dysgenic tissue. So bless you for taking care of the kids when you see them. And thank you for your expertise and your commitment and your love and hard work that you do when you give to the children that the Lord is best to entrust you with. So, no, it's a lot of stuff there, but anything burning or?
Yeah. I have a question. Transgenders everywhere, which bathroom, this, whatever. Is there any way, unless they're hermaphrodite, is there any way that you can tell, let's say a kid up to 5 years old, that they're transgender, they really should have been a girl, they really should have been a boy, without the physical micropenis or whatever?
Yeah, so there's always genotypic, which is confirmed genetically, and phenotypic. So there's phenotypic expression, what you see, and there's genotypic expression. And sometimes testicular feminization is a true genetic as well as phenotypic expression. Testicular feminization used to be that runway model. She was tall, she was long, and she was also had testes. But they weren't palpable, and she looked very feminized, but her gonads were not ovaries, they were testes that were intra-abdominal. And that's why she became so tall and broad-shouldered, and the only thing that had to happen there is these testes that are intra-abdominal can degenerate and may be led to gonadoblastomas, so you remove those at a certain point in time. But it didn't have to be removed early. For the little girl that presented because they felt she had a hernia, and at the time you do the hernia repair, boom, out comes a gonad, and you go, that's not an ovary, that's the testes. That is a time when you would not freak out, but go, okay. And then you could remove that at that time or put it back in and let them go through their full maturation. Know that you'll come back and remove that laparoscopically at some time later. So if a young lassie presents with bilateral hernias and they go for bilateral inguinal hernia repair and you find tissue, be prepared that you may come across that. So I'll even tell the parents before we go back, we're going to go back and do the repair. Sometimes we may find something other than a hernia in this situation. Now, if it's a true gonad, you feel above and beyond it, right? You feel there's something that's specific instead of bow or something that's coming and going, but you actually feel something semi-firm. So sometimes an ovary will actually herniate into a hernia sac in the gal, but if it's firm, it's good to be prepared that might be what you see. Now, to your question about transgender, as far as how one looks or how, it's such a loaded question,
Does a 5-year-old know that they're the opposite sex? And you're not going to do a sexual transformation surgery on a 5-year-old or a 10-year-old or a 16-year-old.
Most of this stuff nowadays is identified in the neonatal period, and that's why it's a neonatal crisis. So if I get called to come see a patient of potential intersect abnormality, just based on examination, the most common would be congenital adrenal hyperplasia. CAH, which is an enzymatic deficiency, not a genetic deficiency. It's an enzymatic pathway that leads to a masculinized woman. And so the clitoris is enlarged, they have a large dorsal hood, and they have aberrances and sometimes even vaginal growth and stuff. So that is something that needs attention and direction, but it's mainly enzymatic correction. But if that child leaves the hospital and didn't get specific enzymatic testing, they may have a salt wasting condition that can lead to mortality. That's why 17-hydroxyprogesterone is almost always obtained as an almost routine blood test before. So why don't you do 17-hydroxyprogesterone? What are you doing? But that's more, because if that slips through the cracks, you can have a fatality.
Scary world.
So almost all this stuff is identified now in the area. But that's a crisis. That's let's see what is the underlying condition. What does that potentially lead to down the road that you can start on a path. And I have pretty good connections with Children's Downtown because we're all, a small group, and they have an intersex, clinic that specifically for parents and everybody with more complex things that they should really be plugged into. For me to walk them through that completely with an endocrinologist locally may be out of our realm, but we see, what's necessary. It's always help. And isn't it weird, so it's how you feel today decides where you go, today I just feel like a woman. So I'm going into this bathroom today. No, you're not. You want to go in there and check something else at you. Schwack!
Yeah, that's what the schools are putting up with, Well, I feel like a boy, so I'm going to go in the boys' gym. Well, it's more pathetic for a boy to feel like a girl to go in the girls' gym class. I'm glad I don't have kids that age. Yes. It's scary.
Well, thank you for your attention and staying late.